for pain. All right, that's what we're doing. And we're not,
You were
what is
not in
percussion?
there. It's tapping and listening.
Yeah, percussion is when you usually put your fingers over the area and then you tap on that. And depending on what you're listening for, it's going to, if you're over organs, it's going to be a dull sound. If you're over open cavities, it's going to be a hollow sound. But you'll learn that at another level. So we're not doing percussion. So that's your abdominal assessment. When you do your abdominal assessment, do you think this is a good time to ask about their bowel elimination? What are we going to ask them? When was your last bowel movement?
How often do you have
How
bowel
often
movement?
do you go? Was it normal for you? Okay? And that's the thing, is finding out what's normal for that patient. Because some people, what's normal for them may be horrible for somebody else. Some people go every day at the same time. Some people go once a week. Alright? So you have to find out what's normal for them. Do they take any medicines for their bowel elimination? Just find out. This is the time to explore. And while you're assessing the abdomen and you're being very professional and you're asking related questions, the patient usually will freely answer. Okay? Also, when we're in this area, it's a good opportunity to ask them about their bladder elimination. Huh? When was the last time you voided? Emptied your bladder? Okay? You can ask them what it looks like. Is it clear? Is it cloudy? Does that have a foul odor? And sometimes that goes along with our symptoms that the patient's exhibiting as well. And what else can we ask while we're asking questions?
Does it hurt when you go to the bathroom?
Ooh, good question. Yeah. Do you have any pain? Or do you oftentimes, do you have leaking? Do you have urgency when you go, you have to go right now? Do you think this is a good time to ask about genitourinary, like do you have any vaginal discharge, about your menstrual cycle?
Right.
Yeah. And those kinds of things, if they're not there for that reason, it's hard to remember to do that. But we'll give you a guide, and you can always go back in the room and ask the patient at another time if they have any problems in that area. So that's the torso. I think we've finished that. So now we're going to move to the lower extremities. Okay? Now when we start with the legs, now we've already checked the strength in the upper arms. We've already checked the pulses in the upper arms. So when we get to the lower extremities, remember when we did the arms, how she raised her arms against the resistance of my hands? When you do the legs, you have to do them one at a time. Because if I put my hands here and I said, I want you to lift both legs, it's hard, isn't it? So you don't get a good assessment. So I'm going to put my hand here, and I want you to raise your leg against, okay? So one at a time. Even if they're lying in bed, think about lying in bed and lift both legs off of the bed. It's hard. So we do it one at a time. Okay, you can also do the lower leg by kick out against my hand. And then even the feet. But this, really the quads are all we're going to assess. In terms of strengths, we're checking the arms, the hands, and the quads. Is that what you want?
Yes.
Mr. Holmes? Okay.
Perfect.
Huh?
Why do they check it though?
I thought it was for the number 11 cranial nerve, I thought it was.
Can be, it certainly could be that they had a deficit in a cranial nerve, but it's just, we should have a certain amount of strength, right? I mean,
If they've
but
had a
is a
stroke.
90-year-old gonna have the same thing that
No.
so it's what's normal for them?
But do we want it to be equal?
Yes.
Yes. That's the key right there, is you want it to be equal. Then I would check her posterior tibial pulses and her dorsalis pedis pulses. All right.
Y'all been practicing that?
Yes.
Now, that's the whole body. And I know we did half of it last week and part of it this week. The one thing we really didn't talk about last week was when you go into the room, You need to check every tube that that patient has. And I think that's one of the biggest complaints from the upper level from the instructors is they're not checking the equipment of what they have. Now, last week we had only one patient in that bed, and I had these IV fluids hooked up to the patient.
Now, is Ms. Klauber saying change anything?
No.
Is she saying stop
No.
anything? No, she's saying look and see what you see.
Right. Maisha said, make sure you've got the proper fluid hanging. What do I have hanging right here? Sterile water. Is it a common mistake to have the wrong thing hanging?
Yes.
Unfortunately, yes, because there's so many similarities in terms of how much sodium or how little sodium, so you have to read the bag. And usually when you come into the room, at the end of the shift, nurses are trying to get out of there, they're hurrying, they grab the next IV fluid and hang it, and it's wrong. So that initial assessment is probably your biggest one when you come in. You are gonna hone in on this bag of fluids. You're gonna check, she's right, see what's hanging. What else are we gonna check? How much is in there? Yes, we're gonna check and see how much is in there. And y'all, these bags hold 1,000 milliliters, and they're counted, they're marked in increments of hundreds. 1, 2, 3, 4, 5, 6, 7, 8, 9. So when you're looking at it, you kind of have to read it backwards. Because when I look at this, I don't have 750 or 650 cc's. You have to kind of count backwards, 100, 200, 350. And you can take the bag on either side and kind of pull the seam, and it kind of gives you a more accurate assessment. And she was exactly right, there's 350 cc's of fluid in here. You also want to check the expiration date on the fluids. This one expires in 09. All right? What else did you say we want to check? There's a lot of things we look at.
The rate of flow.
The rate of flow, and I don't have this hooked up to a pump, but you would check the pump. And when you take report in the morning, they're going to say, Ms. Jones has sterile water infusing at 150 cc's per hour, and you look at that 150. That's what it should say on here. What if it says 100?
What's wrong?
That would be too slow. That's right. It's incorrect. It could be a mistake, or it could be that we have another fluid hanging like an antibiotic, and it's going in at a different rate. So you might have to check to see if anything else is hanging and infusing into this line as well. And you'll learn about that later. Or, let's see what else could be going
But
on.
if it was 100, would you change it back to 150?
No.
No. What would you do?
Check the orders and
Check the orders.
Check the orders, and for sure you would, in this case, you'd go see the nurse and say, because she may have changed it intentionally for some reason, we don't know.
The doctor may have come in while you were giving a bath to another patient, and they changed the order.
So you would definitely not touch, not change. You're assessing and you're talking to the nurse.
You're reporting,
Reporting.
okay? So we've checked the rate on the pump. Now, what are we going to check about this? We're going to check the IV site. What are we looking for, Lauren? Any redness, swelling, heat, irritation, heat.
Make sure it's that backed up, or not flowing, it's not flowing.
Right. What if this has become kinked and it's come out of the vessel and it's infusing into the tissue? Does anybody
Ow.
know what that's called?
infiltration.
Infiltration.
Mm.
Is it pumping into the tissues? Yes, because it's hooked up to a pump.
Right.
So it's pumping it in there.
Ow.
Is it going to be swollen?
Yeah.
Is it going to be hot?
Mhm.
No.
No, oh, it's gonna be cold.
It's going to be cold.
Yeah. it's gonna be
That's
cold.
your difference And whether it's an inflammatory process, which is indicative of an infection, which Lauren said, or an infiltration.
Have y'all ever seen one, anybody in here seen a real infiltration?
Dialysis,
Have you?
yes.
It is not, it's not a good thing, people.
Mm.
And it's like, you need to fix it.
Yeah.
So, would you fix it, or what would you do? If you went in and assessed, found the infiltrated, IV site, what you gonna do?
Take it out and stop it. And
No,
no?
you're not touching anything. What are you gonna do as a student nurse here?
Oh, it's a student nurse.
You gonna go get the nurse.
Yeah, yeah, go get the nurse.
You gonna stop your
Yeah.
assessment?
Yes, if you were the nurse, you would.
I'm
Yeah.
sorry, as a student nurse, I'm just trying to get y'all right now not to be touching stuff because you're gonna be tempted. You go get the nurse straight away, stop your assessment, go get them, bring them back. We need to get these things fixed right now.
Is it gonna hurt?
Oh, gosh, yeah.
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 It burns.
Yeah, it's, okay. So yes, you're gonna check the site as well. We're also gonna check the date. How long is an IV site good for?
3 days?
3 to 72 hours.
Does that vary by agency, cause
Yeah.
It is,
It
it
does.
is protocol, but normally about that.
So what do they do? Put a new one in?
Yep.
Yeah.
They start a new one. Why do you think that is, y'all?
Infection?
Infection.
Infection, what is that, what is that cannula? What is that IV cannula?
Oh, a portal.
Portal of entry.
It's a portal of entry for sure, okay?
And sometimes depending on the patient's situation, we won't change it because they may not have another vein. And oftentimes we'll start another one before we get rid of this one.
You have to get an order. It says, don't change it. But there are hard sticks in this world.
Okay? Anything else about the IVs? Anything of?
Just be very cognizant, be very attentive to them. It's an artificial machine that's affecting that it's a lifesaver, but it can also be a very bad thing in a hurry if it's not managed correctly, okay? So you always look at it. And that IV site, that's the big thing. I think it'd be red, puffy, and the next thing you know, they've got an infection
They got a line going up there.
going up their arm, and then they're gonna have an IND.
So why did I wind up with
What's an
several
IND?
red spots?
Incision and drainage.
Incision and drainage.
What?
So, because
Why did I
the
wind up
vein
with
is
several red spots from
infected
one
on the
IV?
inside, they have to cut it down, butterfly it open, and let it heal by secondary intention, so that it heals from the inside out. Just because they didn't change the IV or manage it correctly, that patient's in the hospital extra 4 or 5 days. So like, not good. And the nurse is responsible. It's like, you harmed them. Are you supposed to do that?
No.
No. Okay. That's all I can think of.
It causes a little cyst in your hand whenever with the IVs too. Sometimes I've noticed. Like with me, I get from my IVs I've had. Oh,
Scar tissue?
yeah. It's just crazy.
Student running.
What about a Foley catheter? And I'm gonna bring a Foley bag in here.
Check the bag.
Check the bag, yes. What are we checking for?
We want to make sure it's
How much is in it?
Right.
The color?
That it's filling up at the proper amount. What is it? 30 cc's per hour.
25 to 30 cc's per hour.
Right.
Now
If
that's minimum, right? You make way more than that whenever you go out clubbing. Or you're making a lot of urine, right?
Yeah.
Why are we?
Engage us
some-
all.
The intake.
Am I gonna bring them back?
Yeah, sure, absolutely. It's the intake, right?